also to increase our compliance to 100%. Now going to the baseline. So moving to the baseline at MP Shah Hospital, in the year 2022, January, February there, we noted a high number of handing over related incidents. This was a total of 7 incidents in a span of only 2 months. For us, this was high and we needed to do something. So looking at the root cause analysis, the problem was high number of high handing over related incidents, talking of a whole 7 in a span of just 2 months. So under method, the findings we found there was that our existing policy was inadequate. It was not adequately addressing our handing over needs. The audits we were doing were not enough to at least pull out what we needed to improve on in handing over process. And also the feedback process was inadequate. The other finding here was delayed and inadequate root cause analysis process, especially for those incidents affecting IPSG and particularly handing over process. The other bit was just culture process model had not been rolled out. And as a result, after incidents are reported, there was that feeling by some staff that they were being punished even for system issues. Looking at the man aspect, the causes we found there was inadequate staff training. And the other bit was our induction process had not really picked up, especially on nurses induction and on the aspect of international patient safety goals. We looked at our machines were innocent. We looked at materials, and what we found out here was lack of enough standardized handing over tools within the hospital. So what we needed to do was to move to interventions quickly. So our aim, as I mentioned, was to improve handing over process at the MP Shah Hospital. And this was through the use of standardized tools and content to reduce handing over related incidents to 0 and to increase our compliance to 100% by June 2023. So under the drivers, we implemented some improvement ideas. And the method we went ahead and revised our existing policy, looking and linking it with best practice, and we made sure it captures what we need to implement as a hospital for an effective handing over process. The other bit for our root cause analysis process, and for IPSGs, we made it mandatory that a quality improvement officer has to coordinate this particular process, just to make sure we can ensure the credibility of the RCS and we can be sure to follow through and make sure we complete them well. We rolled out the just culture process, and this ensures that we don't blame staff for system issues, and at the same time, staff are held accountable for where it's required. The other bit we rolled out was monthly audit, and what we ensured for here is we have timely feedback to our teams and support through our quality officers. Looking at the staff aspect, what we did was all staff trainings on handing over process and the entire IPSG training. Here we used face-to-face, we used virtual platforms, and we even went ahead and rolled out a Google Classroom, whereby it made sure if somebody is not able to attend the face-to-face, they have a safe-based approach of reaching and making sure they trained all of them. Then we incorporated our international patient safety into the new nurses induction process. So this is something which is mandatory for all new nurses, which we take them through. The other bit was biannual patient safety campaigns. This we do twice a year in the month of March and in the month of September. The other bit we also rolled out was rewards and recognition. We really recognized the teams for doing well, and especially in terms of quality improvement. And the materials we looked at our tools for handing over, and we revised them, and we made sure we have adequate good tools which have standardized content for all our teams, for our doctors, for our nurses, and for our other clinical teams. Now moving to the results, what were our results after these interventions? So one of the things we were looking at was handover related incidents. I mentioned that we started with 4 in the month of January, then 2 in the month of February 2022, making a total of 7. We were able to see this reduce drastically as we went over through the months. And by the time we were closing this in the month of June 2023, we are happy to see that we were able to have reached our 0, which was our target. The other aspect we were also looking at was our compliance. And here we usually or regularly audit on a monthly basis the compliance rate for, that should be the next slide. We usually regularly audit compliance rate for handing over process. We have tools whereby we are able to look at all aspects of the handing over process. And at the start of this project, our score was 74%. We were happy to note that we were able to improve this, and by the time we were closing this, because something we are continually even monitoring, we were able to close this at a score of 89% in the last month. The other bit we were also able to look at, which we look at regularly, is our culture of safety. And there's a composite which looks at handoffs and transitions of care. One of the things.
Jean, kindly address the mics that are supposed to be off. Thank you. And bring back the slide.
Yes, I think it's started now.
Okay.
Jean, please unmute.
Am I muted?
Thank you. So looking at our culture of safety, one of the things we usually look at under this survey, we use a tool which is from the Agency for Healthcare Research and Quality. And one of the composites there is around handing over and transition of care. And here, under these areas, we look at those staff who are giving us positive feedback, meaning the ones who are either disagreeing or strongly disagreeing with the areas here. And one of the things we were able to see is an improvement over the years. Looking at the first one was that things fall between the cracks when transferring patients from one unit to another. We were happy to note that this has improved over the years from 53% to 60%. The other bit we look at is that important patient care information is often lost during shift changeover. And here again, as I mentioned, we're looking at those disagreeing and strongly disagreeing. We were happy again to note that this improved from our baseline of 68%. We were able to close it at 74% this year. The other aspect is problems often occur in the exchange of information across hospital units. Again, here we were happy to note that we were able to improve from a baseline of 52% to 61%. And the last one was shift changes are problematic for patients in this hospital. Again, here looking at those staff who are disagreeing or strongly disagreeing with this information. And again, we were happy to see that we were able to improve from a baseline of 64% and 71%. And the other thing we were happy to note as a hospital is that we were able to, in all these aspects, do better than the benchmark which we are working on. So now moving forward to the next slide, the other bit we are looking at is the lessons learned, because this is a project where we were able to get very good lessons, which we are happy to share this evening. And one of the lessons is clear policies. It's very important that we have clear policies in place, policies around handing over, and policies around all the aspects within the hospital. That should be the last slide. Thank you so much. So clear policies around handing over, this was very key for us as an improvement. The other aspect was standardized tools. Standardized tools for handing over is very important. This was something we found very important, having standardized tools and also making sure these tools are accessible to all users. The other lesson was that staff training, especially on handing over, is very key in this process. And what we are looking at here is the what. What is it? Why are we doing it? Because the rationale is very important. Is in the BSc of our staff. The other sustainability bit we are doing is can
just continue, Jen.
Thank you. Thank you.
Wind up, because yes, the 10 minutes are over. Just wind up. Yep.
Okay, so we are looking at integration to daily standard work. This is something we've done. We've made sure we have succession planning in place, which is something we're working on. The other bit we are doing is visual management. During daily Kaizen board is something we've been able to fix in our notice board, in our Kaizen board for our teams on where they look at on a daily basis. Then we have sustainability champions on the ground, mainly our quality teams and our leaders on the ground. So going forward, in conclusion, what I need to say is that no one should be harmed while receiving healthcare. We all have a duty to make healthcare safe. It can be done through teamwork and guided by evidence-based practice. So this is something doable. And as I conclude, I want to acknowledge my team. I want to acknowledge our board, our CEO, our COO, our senior management team. I really want to acknowledge our nurse managers, our clinical HODs, the staff, because they are the doers of this, and of course, my project team. Thank you so much for listening, and may God bless you.
Thank you very much, Jen. I think we can give an applause for Jen. As we go to the next presentation, we'll have the questions all together. We appreciate that was excellent, awesome presentation. We can give the Zoom claps. Yeah. So Jen, we truly appreciate MPSHA for sharing that. We will welcome Boyce Mutitwini, Level 4 Hospital. Boyce, you're welcome. Kindly take it on.
I am unable to put my video on.
We shall do that, but you can continue presenting. Jean, can you? But it's okay. Kindly just proceed. Eh?
Okay.
Yeah, thank you.
Hello, everyone. My name is Boyce Kitabi, a clinical officer and a CQA champion working at Mutituni Level 4. Mutituni is a Level 4 facility located in Machakos, Kenya. Welcome. Mutituni Level 4 Hospital overview. Mutituni is a public facility located in Machakos County in Kenya, and it has a catchment population of over 16,000. And offering both inpatient and outpatient preventive and health promotive services. In terms of our continuous quality improvement, in this time we dwelled on, we picked up a topic, and that is where we are going to give our story on. That is continuous quality improvement for tuberculosis management at our facility. And I'll start with the definition of tuberculosis. And I can say tuberculosis is infectious disease that mostly affects the lungs, though it can affect other parts of the body, and it is transmitted through the coughing or sneezing, and also spits. In the year 2022, in Mutituni Level 4 Hospital, just a clinic, only 74% of tuberculosis clients on treatment and follow-up converted from sputum smear positive to sputum smear negative at their second month of treatment. This was of our worry, because this one we picked during our WIT, that is our work improvement team meetings, and we analyzed it and realized that we had a bigger number of people who are not converting. That was translating to 24% of our clients at their second month of treatment, they had not converted from their smear positive to smear negative. When I talk about smear, I mean these people at the beginning of their treatment, they were tested and they were found to have the bacilli which causes the tuberculosis. And on the second month of treatment, they are usually screened again through the sputum again, and we usually expect all the people to have converted and to be negative.
Sorry, Boyce, let me stop sharing for a minute and then reshare.
What was our target statement? Our target statement was to improve on follow-up on client sputum conversion rate, and we wanted to lower it from 24% to less than 20%, to lower than 10% in the year 2023. How did we arrive on lowering this? We did a root cause analysis, and from the people aspect, we realized there was a long appointment dates which the clients were being given. And these long appointment dates were due to high workload, because the clinician or the health worker who was at the clinic used to have a lot of high workload. So they could give the clients a long appointment date. There was again another issue in terms of the people. We realized there was no anti-arrest councillor that is in the year 2022, and that would have led to this high failure delay in conversion rate. When we went to the procedures, we realized that without the councillor, anti-arrest councillor, then the first contacts were unable to be given adequate time for the counseling and also on anti-arrest in terms of the treatment. When we came to policies, there was nothing which was so striking in terms of the policies. But when we came to the environment where these clients are coming from, we realized most of them, they are a bit addicted to drugs. They would come to pick their drugs when their commodities when they are drunk. They were still persisting on smoking while they were taking their treatment, and such would have led to poor adherence in terms of treatment. In terms of prevention, though we had some times the stock of the commodities would go low, but there was no reported time when the patient went home without the drugs. From there, how could we intervene so that we can get into lowering this delayed conversion rate at their second month of treatment? We intervened with several interventions. First, we said we need to assign someone specifically to be seeing these clients, because now we do not want them in the year 2023 also to be given a longer appointment dates because of the workload. The other thing we said, we need to continue tracking or monthly tracking on the conversion rate. That is following up from the laboratory so that we can get at least every month we can know how many people have not converted at the second month of treatment. The other thing was tracking on the areas where we had high prevalence rate in order to engage our public health officers so that we can do mop-up and do the community sensitization in terms of how we can reduce TB transmission and reinfection. The other thing was to emphasize on first contact thorough counseling. Now that we had to get a counselor in the year 2023 so that at least the new clients can understand why they are taking these medications and why we need to keep on tracking on them so that we can see their progress. The other thing we put in place was to ensure counseling on social behavior change, especially in those clients who we realized they were still taking our medications, and they were still coming to pick their drugs when they were drunk, and also they were mixing with the cigarette. The last but not the least was also to maintain our quarterly work improvement team meetings, at least to continue reviews on the progress of our program. Then this is the graph about how in the year 2022 we had a delayed conversion rate. As we can see, in the month of January, that was a 33% delayed conversion rate. This means for every 10 people who were being followed up at their second month of treatment and who are taking treatment, 4 of them, they were still sputum positive. In the month of February, we can say again, out of 10 who were tested, 5 out of them were still active. So that means they were still having they had active bacilli, and still this could lead to more transmissions, more to drug resistance, more and such. But when we go to the percentages after interventions, we can see clearly that the comparison between the year 2022 and the year 23 when we started the intervention, the blue line marks the year 22 and the brown line marks the year 2023. We can see from the month of January, where in the 2022 we had a high cases of delayed conversion rate of 33%. In January this year, we had 5%. That means out of 10 people, less than 1 person had a delayed conversion rate. In the month of February, we had low cases. In the month of March, we had low cases. However, from the graph, you can see from the month of April, May, and June, the graph in the year 2023 also took the shape of the year 2022. And there are lessons we learned out of these graphs. But as we can continue from June, July, August, we can see the trend is still going down. What are some of these lessons that we learned? Because from the beginning, when we saw the delay in conversion rate, we planned and took an action. But what are these lessons that we learned? One, we learned that when we give individualized counseling, then it improved on the outcome. And what we are seeing from the month of April, May, and June is we realized that month the health worker who was assigned to be attending these clients who are for the TB then went on leave, and these clients were now put to be seen with other clients. Now that means the aspect that of workload again had a role and made our graph again to resemble for the graph for the year 2022. What other lessons did you learn? That continued close monitoring analysis of the trends. Still, it can, at least it can alert us when things are moving wrongly. What are our sustainability plan now that we realized if we are not in, things can go wrong again? We said we need to sustain monthly tracking and charting on conversion rate. And we need also to ensure good adherence, counseling and support and monitoring treatment progression. We need also to assign someone specifically to be attending to these clients so that we don't have a high workload, making our clients the adherence to be poor. Another thing we said we need to do is to maintain our quarterly week meetings, because this is where we brainstorm and we are able to note some of the challenges and some of the failures in terms of our service delivery. In conclusion, I can say that it is quality rather than quantity that matters. It is not about the number of main patients we see, but the quality of time we give to these clients, and the improvement of one-on-one care and counseling is crucial in improving TB treatment outcome. From my end, as I conclude, I acknowledge the support from the county health team that starts from our governor, all the health teams. We have our county and sub-county TB coordinators. We have the sub-county HMT leadership, which always keep on tracking and seeing how we are faring and doing our activities from our facilities, and all Mutituni level 4 hospital staff, starting from the lab people, the chest clinic people, the clinicians, the pharmacy. Thank you so much.
Thank you very much, boys. We can clap for boys as we have the next presentation being loaded. That was impressive, coming from a private facility, MPSHA. Now we have seen a public facility, level 4, Mutituni. So I think we are really glad that we are having a whole spectrum. Kindly share the slides for Marble and Joy. Okay. So we are waiting for the slides to be projected. Great, Marble, you can take it on.
Good afternoon, everyone.
Good afternoon.
So my name is Mabel, and I'm here with Joy. We are representing Focus Orthopedic Hospital. Can we move to the next slide, please? Okay, so our QI improvement project was on establishing an adverse event and incident reporting mechanism in Focus Orthopedic Hospital. Next. So here is our wonderful team. On our left is stakeholders meeting, where we have our CEO and various heads of departments sitting for a training and a meeting in relation to the KY project. And then on the right, is our quality team having their brainstorming session. Next. So the aim statement was to increase adverse events and incident reporting among our hospital staff by 50% from the month of January 1st, 2022 to 31st December 2022. So we're giving a little bit of a problem background was that in 2021, we observed that most of the incidents that were occurring within the facility was left unreported by our employees. So as you can see from the chart, the whole of 2020, we only recorded 7 incidents. And then in 2021, we also recorded only 11, which made these incidents that do occur, reoccur, and reoccur, which cause harm to some of our patients. Next slide. So as a way to solve this problem, we did our root cause analysis, and 3 major factors stood out. So taking the first factor, which was on procedures, we realized that there was no policy in existence that was giving us a clear guidelines on what to be reported as incidents, when to report it, that is the time frame, and even where to submit the reports when it happens. And secondly, we also realized that the existing forms that we had in the system were being kept only at the quality department. So when incidents do occur at the various units, they have to walk to the quality department and come for the forms. Thirdly, we also realized that the existing forms in the system was so complex. We had about 5 different incidents. Which form should I complete? What should I write? And all that. And that was really a problem for most of the employees. That was the organizational factors. We realized that there was lack of training. For a whole year could go and we would not do any training on incident reporting. We also realized there was a blaming culture, so that anytime that there is a problem, the first question to be asked is who caused it, instead of us focusing on why. To even report as an incident. 2, we realized that there was fear of being punished, because in past years, people have been sacked and all that because of incidents that occurred at the work shift. And also we realized that people were downplaying the magnitude of the incident, especially if it is a near miss, then they don't see the need to report some of these incidents. And then we also realized that co-workers were influencing one another. Oh, don't report it. Even if you report it, you will end up being punished for it. So all these things were contributing to the fact that they were not reporting the incidents and adverse events that were occurring within the organization. So how did we move from this? Please, next slide. So we had to come up with intervention to solve the problems at hand. So the first intervention that we came up was to develop an incident reporting protocol, which really stated what should be reported, within what time frame it should be reported, who should they submit the forms to. So all these things were spelled out in the incident reporting policy that we developed. Then we reviewed the existing forms, that was about 5 different forms, into just one forms, which made it easier for people to then know exactly which form to complete when an incident occurred. We also did a lot of sensitization by creating more awareness on why it is so important to report incidents within the facility. We also had training across the various units. We didn't lump them together. We did it department by department in smaller sessions, so that we made sure that they were really getting us, or they were really understanding our point of view and why it's so necessary to report incidents. Next slide, please. So this is the results post-intervention. So as you can see from our baseline of 11 in 2021, we had a rise in 2022 to a total of 47 incidents being reported. This indicating about 327% increase in our incident reporting. And in 2023, as at the mid of the year, we had about 59 incidents being reported, which was also about 436% increase from the baseline. Next. In terms of our monthly average, in 2020 and 2021, sometimes in some of the months, we will not have a single incident being reported, but we saw a change in 2022 that we had a minimum of 3 per a month. And in 2023, we had a minimum of 7 per a month, which was quite an improvement. Next slide. In terms of participation of the various departments, from 2020 and 2021, we realized that only 3 departments were making it a point or were making efforts in trying to report incidents. However, the remaining departments were not reporting any. However, after our post-interventions in 2022, we had 14 departments being on board. And in 2023, now we have all our units and departments of 21 really reporting an incident this year. Next slide. So what lesson did we learn during this process? First one was leadership support. We needed the leadership to promote or to show our staff that they are buying into the just culture, and that when staff make errors, they wouldn't really look at it from whose perspective, but then they will look at system improvement. So leadership from that point started promoting the just culture, which really helped this process. We also saw that teamwork and interpersonal relationship skills also helped, because we involved all the major stakeholders right from the word go. Therefore, during the implementation phase, it really made it smooth for us to implement our policies and protocols. And then intrinsic motivation also really worked for us. I remember when we started, our CEO promising various heads of department that the staff that comes out with quite a number of incident reporting by the end of the year, she has a token for these departments, which was very exciting for all of us to get along. We also utilized external support, which was also essential, because this external support helped with the sensitization. At times, they need people outside the hospital to let them see the picture we are trying to paint. So this also was something that we learned, that it helped our KY project. And then we also learned that clear guidelines and less cumbersome processes help with compliance and adherence, because when the process is too cumbersome, they feel very lazy to really adhere to it or follow the steps. So we also learn to keep our processes simple. And then continuous training. It is always important to bridge that knowledge gap and bring people to speed so that they would understand what you want them to do. Next slide. So how do we intend sustaining all this major improvement that we have done? So we went on to monitor all the things that we were doing. For example, we were collecting data, analyzing and trending them every month to see what were being reported, which department was reporting, what particular kind of incidents were being reported. And it didn't end with just the data analysis. We move on to sending it to QI committee meetings every month for reviews. That is where we approve on the various corrective plans, and then we put up timelines on when we were going to finish all these corrective actions. And then when we end from the QI meeting, we don't end it there. We push it back to the stakeholders. Giving feedback is very important in QI improvement projects. So we give feedback to the various departments we share with them the corrective plans, and we all carried out the improvements together. And then the next thing was to make the incident report forms available in each department so that they wouldn't have to walk back to our unit for forms. So now we have put up pouches in every unit that has the incident reports in those pouches. We have also incorporated it in our hospital information system. So once an incident occurs at shift, it's either you get to the pouch, take one and complete it, or you go into the hospital information system and complete it from there. And then continuous training, which is very essential. Now we have included it in our orientation pack for every new staff who is onboarding. And for regular staff, we do it every quarter. So at the end of the year, at least you have 4 trainings on incident reporting. That is if you are a permanent staff. And if you are onboarding, you do it right from the beginning so that you understand what it means to the organization. Next, please. So what are we saying? We are saying that clear guidelines and protocols makes it easy for people to improve adverse and incident event reporting. And also we are saying that to err is human. So we should always know that as human beings, we will make errors. But when the errors occur, we should approach it with a learning attitude. We should always know that human beings are the same people who are doing the work, and they are the same people who will make the errors. So when we approach it with a learning attitude, we are able to improve the system, which makes the system safe for us and the patients as well. Thank you.
Thank you very much, Mabel and Joy. That was a great presentation. I think this was like a class of how things happen on the ground. There's something special about sharing from somebody who's doing the work. And we felt that through the presentation of Jen, of Boyce, and even this last one by Mabel. So I am not seeing any questions here. In case you have any questions, you can kindly type. We want to catch up with time. But there is one for Boyce about whether you encountered the multi-drug resistance TB and whether that was affecting the delay. I think you can speak to it. And in case anybody has any other question, they can type so that we proceed with the next. So Boyce, kindly, you can respond to that.
Yes, we have different modalities on now of testing for our clients. And as I said, we were tracking on those who had not converted at their second month of treatment. And we know the MDR, that is multi-drug resistance, can be also be among them. But from the year 2022, we only had one case. And that is the case which crossed over even to the year 2023. But now we are looking at a conversion from the second month. So the patient did not fall in any of our data. Thank you.
Great, thank you very much. We propose that we could put the questions on the chat box. This was music to our ears, seeing the driver diagrams, seeing all the fish bones, and having sustainability plan. Great work. So I think we will go to the next. Alex, did you have a question? Okay, can see you are new. Great. Allow us to go to having remarks from the evaluators. We had a splendid group of evaluators that represented the continent, and they will introduce themselves and give some remarks. By themselves, they are a quality experts in the field, in the engagements that they're involved in. So welcome. We will start with Grace Ndegwa. Grace, you're welcome.
Thank you, Dr. Okutoi. Good afternoon, everyone.
Good afternoon, Grace.
I'm glad to join you today as we celebrate outstanding stories of quality improvement in Africa. As mentioned by Dr. Okutoi, we are champions of quality of care and patient safety. So I work with an organization that carries out quality healthcare awards, which has been running for the past 5 years. And we seek to create an environment that demands and promotes equal access to quality, patient-centered care, and also engages and empowers people and communities to drive quality. On to the QI contest. As the panel of evaluators for the Acquire Storytelling contest, we reviewed over 40 QI initiatives that had met the set eligibility criteria. So there were more, but those other ones had not met the standard eligibility criteria. And we acknowledge that the initiatives were very innovative, which are initiatives and interventions by frontline workers towards improving patient safety and quality of care in our health facilities. We had strong contestants from different countries, including Ethiopia, Tanzania, Ghana, Kenya, Cameroon, and Malawi. The QI Storytelling Awards that are going to be bestowed today will recognize contributions by the frontline workers towards improving the quality and patient safety with a focus on innovativeness, stakeholder involvement, effectiveness in testing change ideas, efficiency of the interventions carried out, use of data to make informed decisions, the impacts of those interventions, either on patient outcomes or hospital systems, and the proof of continuous improvement. As we know, quality is a journey, so you must keep on working on improving the quality of care that is provided. We also looked at sustainability and also the potential to replicate and scale the interventions that were presented by the applicants. I believe that all of you have received insights from the QI interventions that were presented by the shortlisted finalists, and we are optimistic that the approaches will be replicated by you, the frontline workers across the African region. The Patient Safety Day was celebrated this month under the theme, Elevate the Voice of the Patient. And as the frontline health and care professionals, let us all work towards the delivery of quality people-centered care that is responsive to the needs and also the expectations of the people, and to continually monitor and address any emerging gaps, given that patients should be able to count on receiving safe care that will improve their health and not cause harm. On these notes, it's important to point out that around 1 in every 10 patients is harmed in healthcare, and more than 3 million deaths occur annually due to unsafe healthcare, although more than half of the harm can be prevented, and this is according to the WHO. For this reason, we would like to promote a culture of continuous quality improvement in Africa to ensure improved and sustainable health outcomes. This can also bring about job satisfaction to the health workers. And in closing, my sincere appreciation goes out to the Acquire team for organizing this contest, which has created a platform for the health workers to share their interventions, their success stories, which the people can learn and also share with other people who have not managed to be part of this platform. I would also like to recognize the panel members, my fellow panel members, for their remarkable contributions throughout the review process, and all the participants for sharing their work. I also take this opportunity to congratulate the winning teams. We're going to hear who the winners are, and congratulations to all of you. And to also those who participated, as much as you have not been shortlisted, we believe that you're doing great work. Keep at it. It's all for the patients. When the patients win, we also win. With those few remarks, it's my pleasure to invite the evaluation panel members. Elom Ochi, who is the Technical Director, Africa Institute of Healthcare Quality, Safety and Accreditation, and Jackie Stewart, the CEO of the Council of Health Services Accreditation of South Africa, COSASA. I think Elom will be the first one to take over. Thank you, everyone.
Yes, so thank you very much. And I would like to say congratulations to the award winners. You have done exceptionally great and exceptionally excellent. And for me, the lessons for all others who are on the call should be that once it has happened in Kenya, it has happened in Ghana, it has happened in Malawi, it can happen anywhere. It has happened in a public facility, it has happened in a private facility, it can happen anywhere. It has happened in a large hospital, it has happened in a small hospital, it can happen anywhere and everywhere. And I mean, it should also excite us to know that improvement is possible. Even though it is not easy, with the determination that we all keep, we are able to ensure that outcomes are improved for our patients, and then even invariably ourselves, because there is a very thin line between wellness and health. So congratulations once again. I don't want this to be about me, because we have 3 gallant people we are celebrating. So I'll keep my message short and just to encourage all of us in our quality journey, that it is only a matter of time that we realize that the world will be interested in our work. And the time has come for our 3 colleagues. So it should encourage and excite us so that we can keep up the good work in the very small corners that we find ourselves. Let's brighten the corner wherever we are. And let's always remember that the system we work to improve might either work in our favor one day because we will need it, or it will be working against us one day, because when in our time of need, we will be served by the food we have prepared over the period during our service. So let's continue to brighten the corner where we are. And congratulations, Mabel, congratulations, boys, and congratulations, Jane. Thank you. Bye-bye. And congrats to my colleagues as well, Jackie and Grace, and to the Acquire team for this initiative and for this innovation. So congratulations to all of us. Over. Thank you.
Thank you, Elom. This is Jackie Stewart. I'm the last member of the evaluation panel. I won't repeat what my 2 colleagues have very eloquently said, because I think they really have summed it up. But for me, it was a fascinating exercise to do these evaluation. It was quite long, but it really was fascinating, and it was actually very, very encouraging, because people will tell you things are bad on the African continent, things are not working, particularly in public health systems. There are challenges, people are short-staffed. So it really was, as Elom said, a bright light to see so many entries. And I'm sure there could have been 4 times as many, maybe 400 next time. But they were all very worthy, and people had applied themselves, to improve the life for patients. But in doing so, they also had improved their own working relationships and their own working environment, because they improved their relationships, and they also improved the way that things were done. And a few things that stood out for me that all of them mentioned. One was about knowing your numbers and your data, and using that, analyzing that data to give you information. Because without information, you can't start your quality program. You need to know where you're starting from and where you're trying to get to. So that came up very strongly. Also about some standardization to make things happen the same way right across a facility, however large or small that facility is. And then there was 2 of the 3 mentioned leadership. So I think those are some areas that are really important. There was also talk about a learning attitude, and I think that is so important. Patient safety and quality are the same thing. You can't have quality if you don't have safe patient care, and you can't have safe patient care if you don't have quality. So let's not separate them, let's stick together and keep them together. But it really is important to learn from the mistakes we make. So I thank all for the effort there. And in all of these cases, it was things not being done as well as they could be, and developing a system to make things work effectively, which improves the efficiency, which makes things work better across your facility. So I think it was really, they were very insightful. And just on the patient safety specific one, where Mabel was talking about incident reporting, the idea of having a simple system, I cannot agree more strongly. Don't make it complicated, make it simple, make it easy for people to do, and give feedback, as she said, give feedback so people know what's happened. Grace quoted a number, but I'll also say that adverse events, errors, are now the 3rd biggest killer in the United States. They've overtaken, I think it's respiratory illness deaths. So we are killing people on a daily basis across the healthcare system in the world. But let us focus on Africa, and let us take this competition as a starting point for sharing ideas, telling our stories, and being proud of what we do in the continent. We don't have to go overseas to get everything. Let's look to our neighboring countries and let's share. I think if we take just these 3 and everybody looks, these are replicable. You could use exactly the same process, fit it into the culture of your own organization. But what I heard were 3 people who sounded really happy that they'd achieved something, and they'd achieved something sustainable for both patient and staff safety. So well done to all of you and all those who entered the competition. Huge congratulations. Over to you now, Lydia.
Thank you very much. We are truly grateful for your contribution and the guidance that you offered. We know that this was done in a rigorous manner and by people who are an authority. So thank you that you give us the validity in this process, and just you being champions for quality of safety on the continent. It's also a way of expanding networks and mentorship for the team. So allow me to welcome our invited guests. We have 2. We'll start with Dr. Sodzi Teti. He is the Deputy President for IHI, the Global Initiative. And so, Dr. Tsotsi, you're welcome. We are glad to have you. We know you are a very busy person, and we know it may be a different hour of the day where you are, and you are a son of Africa. Welcome. In Kenya, we say karibu.
Thank you. Thank you so much, Lydia. And I'm very happy to be here. It's not so bad. It's just 2:13 p.m. in the afternoon. So this is a great time. I just want to start by thanking the leadership of Aqua for extending the invitation to me. Also to thank our wonderful evaluators. Your job must have been challenging given the quality of the submissions. And then of course, also thank those who have presented, whether it's about practices, TB care, or increased adverse in quality improvement, where sometimes you would ask, as the reporting is the situation truly worsening? And it is not. It is just reporting that has improved, because as you create a safe space for people to actually reflect on what is actually happening, then you see some of these incidents being reported. And that's what gives us the opportunity to actually address what may be going wrong in the system. So a lot to learn. And also connecting with why we are all in this space to begin with. You know, it's one thing setting the standards in quality assurance that people may aspire to, which is also an aspect that we need to pay attention to. And then, but when you get to the team-based approaches, where people are using tools like driver diagrams, root cause analysis, brainstorming techniques, and all of that, it's really very energizing, because then it's frontline led, management supported, and it's about driving the performance to a totally different level. So in this case, people are reporting over 300% increments. And in the case of the improvement in handover practices, I see that you're starting from a range of 50 to 60%, and you're ending up in the space of up to about 72%. So a total change in the performance of the system from what it was to a totally new level. So again, I just want to celebrate all the presentations, and by extension, all of the submissions from all over the continent. I just would like to also say that this platform that Acquire has created for us to share our stories is very important, because then you would see that you're not working in isolation. There are many colleagues working in different places trying to accomplish similar goals. And the more we can share on what is working, the more we can celebrate, the better it is for all of us. I do some work also with ISQA, and I just wanted to share a little bit also about a platform that ISQA is creating, which is the International Journal for Quality in Healthcare Communications. And we promoted this and spearheaded this because we realized that less than 5% of submissions to the ISQA journal were actually from lower middle income countries. So we created that International Journal for Quality in Healthcare Comms as an alternative, as a platform that, whether it's technical reports, technical briefs, a lot of the work that you have presented should be an opportunity for you to showcase. So please look it up, because a lot of what you have shared can easily be written up, and then, you put it out there. Again, it's an opportunity to share across the continent and even globally. So to keep my comments short, again, to just thank you for inviting me here. It's been an awesome 90 minutes. Have a great day. Thanks.
Thank you very much, Sodi, and your work at IHI. We have benefited as a continent. We've done the Open School. IHI stands for Institute for Health Improvement. And so it has impact, enabling us to get agile skills for quality improvement at our places of work. So, and as Acquire, we've also done the Joy at Work with 3 hospitals addressing matters of burnout among the healthcare workers. So, Sozi, we are truly grateful, and we honor you coming to be with us. Allow me to introduce another son of Africa, Dr. Kandie. Dr. Kandie, is Dr. Kandie here?
Yes, I'm in.
Great. I'm so sorry that I shared links and they came with my name, but it is okay. So Dr. Kandie works for the Ministry of Health, Kenya, but he's had a career that has spanned all corners of Kenya, being a champion for quality and safety. Kindly introduce yourself a bit more, and then give your remarks. Karibu.
Okay, thank you very much, Okutoi, and I'm very privileged to be given this forum just to listen to the frontline workers. I'm Charles Kandie. I work in the Directorate of Health Standard Quality Assurance and Regulation in the Ministry of Health. We are the champions for quality of care for the country, and we have a strategy as a country on which is called Kenya Quality Model for Health, and it has 3 pillars that help in the improvement. Otherwise, on my part, I would like to take this opportunity to thank the frontline workers, those who participated in the contest, which we call QI storytelling contest. And it was very refreshing to listen to the ones who stood out. The three of them, I was very, I could see what we've been preaching coming alive in terms of doing an root cause analysis, and then coming up with change ideas and that address the problem based on the root cause, and then the implementation part of it. So I'm very grateful to see how it went. But on overall, in terms of coming up with root cause analysis, I saw the teams almost are addressing each area, although we need to have a way of prioritizing, seeing which ones would be feasible and can be done within the resources available from the quality improvement teams. So and of course, I want to take this opportunity to thank the evaluators, Grace Lom, whom we've met before in NQPS meeting, and Jackie. It was also good to turned out to be with the team to see how, as a region, what we are doing and trying to benchmark. And I would propose in future, probably could be having a collaborative on just a problem area that is identified, which is common to all of us, and so that you can see what are the root causes, and of course, individual counties can see which ones are applicable to them and learn from one another. So on my part, I would like to, the teams that presented, I would want to see more on data. How do you identify your problem? Was it through brainstorming? Did you do a prioritization? That's an area that probably in future we would want to see that. And I know we can think big and start small, and the other aspect. So as a country, I would say that we want to see how we've come up with a quality of care framework and certification framework that can help us. It can help facilities, particularly in Kenya. Those who have been trained are given credentials and they can do self-evaluation, and county teams can do supervision. And in this way, health facilities can see where can they concentrate most, which department, is it outpatient, is it inpatient, is it accident and emergency, is it, so I know some of the programs like HIV AIDS program I'll be leading the pace, and they can learn a lot from them. So from me, this is my first time. I would like just to say thank you very much. So for the Acquire team, thank you. Let's proceed on this, and I'm ready to support, to participate in future to see that we are connected in Africa and can be able to benchmark from one another, learn from one another, and see how we can progress improvement of care in this great continent and region. So thank you very much. Over to you, Lydia.
Thank you very much, Kandie. We are grateful for taking time, having those remarks from Dr. Sozi and Dr. Kandie. It is really a show of confidence that we are progressing well. Allow me to go to the next short part, which is the important one. And I'll ask Jean to project the certificate for Jen. And so we acknowledge the contribution of MPSHA Hospital in this, and the team there. Jen made a submission for the MPSHA from MPSHA Hospital. MPSHA is in Nairobi, Kenya. It is a specialist hospital, and it has 214 beds with 2 satellites, and they run many clinics, over 1,000 patients per month, and they are a great private institution. And so the submission by Jen on the addressing the key area was very important, that you were able to showcase how you got the problem identified and addressed, and the numbers. We were able to see the root cause analysis And so we are truly grateful. And so, Jen, we applaud you and we congratulate you for the great work together with the MP Share team. Kindly let us give a round of applause, an applause to Jen using the ribbon button there. You can give a clap. And so, Jen, we acknowledge your contribution. You emerged as the third, and we are truly grateful. We then go to the second, which was from Mutuini Hospital. Mutuini Hospital is in Machakos. Boyce gave a submission from Machakos, Mutuini Hospital, and it was on a subject that is very important, as we are aware that TB can lead to poverty, and it has outcomes that are not desirable when not managed. And so we are truly grateful to Boyce and the Mutuini team. So we appreciate the person who submitted the project, but there is a team behind them. And so may you pass these congratulations to your enabling environment, up to leadership, and you all mentioned them in your presentation. And so Boyce Kitavi was the second in this contest. And so we truly acknowledge your contribution to improvement of quality healthcare. Allow us to give e-claps and thumbs up on the Zoom. Great. And finally, the top emerged for this contest. The winner was Focus Orthopedic Hospital in Ghana. Focus is a specialized orthopedic hospital, and they have been established for a while, since 1998. Of course, MP Shah has been there for much longer. Yeah, and they are 60-bed hospital, and they have a great mission. I remember reading your values, of being people-centered, employee-centric, having accountability, and using knowledge-driven decision-making, which is what you presented, looking at what data is leading, what data is saying. And so for this contest, the evaluators, using the valid criteria that they shared, were able to find Focus Orthopedic Hospital as submitted by Marble and Joy as the winner. And so we applaud and just rejoice with you for the work you're doing. But as we've been told, we are here also to learn. So we hope that this will be replicated. So thank you for telling your story in a manner that we could understand it and feel the impact. And we also, together with these three, allow us to congratulate all the 40 who submitted, because they were truly great submissions. We would not be able to have all of you being the top 3, but we had great stories from Cameroon, from Tanzania, and from Kenya, from Ghana. So we congratulate all of you. And so I will then go to the next part of allowing Ruth Pearl to give the final remarks, including how the process of getting the reward, as was said. However, I'm so delighted and happy that this happened, and that we are starting a movement beyond the award. There is a patient who went home safer, not having been harmed. There was a process that was streamlined. There were healthcare workers that were happy to work in an environment because of the many submissions you made. And so we congratulate the teams and the people who submitted. We appreciate your effort. Thank you very much. Allow me to sign off as I hand over to Ruth Pearl.
Okay, just in the last 1 minute to say thank you very much for giving us your time. All 67 of you that are still here. The question I have to ask you is, will you be able to hear from us? Do we have your email? Are you following us on LinkedIn, on Twitter, on our WhatsApp channel. Please make sure that you leave us with a way to communicate with you, because we will be doing this every month. We want to bring to the fore, along with our partners, all of the quality improvement stories that are happening all over the continent. So please do partner with us. That is the second request. Do partner with us to tell these quality improvement stories, because the science of quality improvement will only move forward when we tell our stories and share that knowledge with those around us. So that is my takeaway. Thank you very much. We will be doing this every Friday, the last Friday of every month, I think, other than December. So you can look out for that. Follow us on our channels. You can share your email in the chat box if you want us to share with you email newsletters, or alternatively, you can follow us on LinkedIn, on WhatsApp, or on Twitter. We are Acquire Frontline Healthcare. From me, this is goodbye. Thank you very much. Thank you to everybody who has been involved, and a big congratulations to the 3 hospitals and the 3 people who have won. We will be in touch with all of the submitters regarding the remunerations by the end of next week. So we will be in touch. All the best, everybody. Bye-bye.
Bye.
Bye-bye. Bye, Linda. Bye. Bye, Mary. Bye-bye.
Bye, everybody.
Thank you for posting your emails. Bye, Jackie.
Bye, Jackie. Bye, Elam.
Bye.
Bye, Soji. Thank you all so much for your work. Bye, Dr. Kandia.
So nione
Sasa hapa itakuwaje? Hali si hali.
mwenye weba kuwendi.
Bye-bye to all.
Have a good evening. Have a good afternoon. Bye-bye.
Wait.
Can get the audio.
No, we go to the Kabaloke. You go to the Kabaloka and go on.
We go.
Look,